Great, thank you. And thanks everybody for taking the time to join us today. Have the privilege of introducing today's panel and being part of the discussion. Today you're going to hear a little bit from our director here at the Healthcare Authority, Dorothy Teeter. You'll also hear from two of our ACH directors, Allison Carl White with Better Health Together and Elia Moore with the Olympic Community of Health. Our ACH evaluation partner, Erin Hertel with the Center for Community Health and Evaluation, and Mark Province, the director of the Office of Medicaid Transformation here at the Healthcare Authority. Again, my name is Chase Napier. I'm with the Healthcare Authority, part of the broader Healthier Washington team, and I've had the privilege of working closely with our accountable communities of health across the state. So today's agenda, we're going to cover the goals of Healthier Washington, and that's going to feature a little bit about the accountable communities of health and why we really believe the ACH model is critical to achieving a healthier Washington. And then we'll be able to look at a video, a real example of ACH in action. And then we're going to talk a little bit about how we assess the outcomes, where we are today, what we've learned from an evaluation standpoint. And we will get into a little bit more detail about the role of the ACHs going forward, including a central role in the Medicaid demonstration. And we'll have another opportunity to see a separate ACH in action and hearing more from Allison and Elia throughout about their experience in Better Health Together and the Olympic Community of Health. And as already stated, we'll have opportunity for Q&A at the end, so please do use that Q&A indicator and submit your questions for consideration and the discussion later on. So with that, we're going to start off with more of a picture of Healthier Washington and where the accountable communities of health fit in. And so with that, I'm going to turn it over to the director here at the Healthcare Authority, Dorothy Teeter.
Great. Well, thank you very much, and Chase, for that introduction. And this is a great topic for today when we can look back over the last couple of years and see how far we've come with our accountable communities of health. To understand accountable communities of health, or ACHs as we will be calling them, you want to know that Healthier Washington is really an embodiment of our commitment as a state to improve both our health systems and the health of the populations in Washington State and the communities within which they live. The three themes in this diagram, which are really the ultimate goals of Healthier Washington, are intended to depict in a cohesive view the various projects that the state and its partners are undertaking. So specifically, there are three areas of focus. One is ensuring that care continues to support care delivered for the whole person. So in other words, not bifurcating behavioral health from physical health, for example. If someone has issues that relate to needs of both care systems, we're trying to integrate that care for the person themselves. Improving the way we pay for services, or paying for value. And the idea here is that as you pay differently for services, you really enable your delivery system to improve the way in which they can care for people, because they have a more flexible approach to how they're receiving payment. And then building healthier communities through a collaborative regional approach. So Healthier Washington, as many of you know and are familiar with already, but I'll go through this a little bit, has multiple implementation mechanisms, which include federal flexibility, which we've just received for the Medicaid demonstration project, the State Innovation Model Grant, or STEM, which is what the beginning of all of this vision and the beginning crafting of the infrastructure that we need to go forward in an innovative way. And also some philanthropic support. You can see that these three mechanisms working together have allowed the state and its partners to move forward on a number of far-reaching initiatives all at once. Some of which I'll call out here, which we're talking more about today, the accountable communities of health. We talked about physical and behavioral health integration, but more importantly, the infrastructure to do the analytics and measurement that we need to ensure that we're both improving care delivery and population health, and providing some of the support mechanisms, again, for our delivery system and for our patients to better participate in modernized ways of delivering care through different payment methods. So specifically for the ACHs, we're going to spend a little bit of time here on these. As part of the overall strategy, the ACHs have been focused on building and strengthening partnerships between providers, payers, and other social supports to carry out health improvement strategies and work towards ongoing sustainable health system transformation. The idea is to bring together public and private community partners. No one partner by themselves can do the work that when you bring everybody around the table, you can do together. And to work within the ACH with its community partners to really understand and bridge both healthcare systems as well as quality of life issues that we want to address. And to coordinate all aspects of care for the folks that live in the region in a better way. And then, again, the ACHs, I think, to me, are extremely important partners for the state. As we begin this work and have done this over the last 2 years, it's hard to really frame going forward what's emerging as necessary and, I guess, vital infrastructure to continue to transform the system that we have in our state to improve health and care delivery. This map shows you the ways in which these ACHs are organized by counties throughout the state. Again, the community-based and cross-sector coalitions are really operating within these very specific regions. These regions were organized as part of the Innovation Plan in 2003 and have been with us ever since in terms of really helping to focus not only the work of the community, but also some of our purchasing strategies going forward. As a reminder, in 2014, the state legislature provided criteria and funding for 2 community of health pilots, and today we have 9 ACHs aligned again with the Medicaid purchasing boundary so that we can continue to move forward regionally, but then also as a whole. And then, again, just to repeat this one more time, I think what's really important is that you can visualize all the different players sitting around an ACH table as they work together to transform their systems. We've got clinical care delivery folks engaged with community-based organizations, social services, public health, housing, and other local regional service sectors that need to be at the table as we're working to transform systems. And in many of our regions, the ACHs are actively engaged with local Indian health services, while the state maintains its government-to-government relationship with tribes and sovereign entities. So those are some videos that we've seen, some visuals we've seen in terms of slides that you've seen before, some of you, and if not, please continue to ask questions about those. But we thought today we would not only want to tell you about the way the ACHs are building these healthier communities, but we also want to show you how it's happening. So the video we're going to show you right now is from the Better Health Together ACH in the Spokane region of our state. So I'll turn it over to our video master to turn on that video.
80% of people who are in county jails have either a substance abuse or mental health issue, and oftentimes it's co-occurring. When we talk about health reform and population health, we will never get there if we can't get a more systematic and organized effort. But it's a very significant part of the population that has these untreated issues.
Perry County is unique. You gotta understand we're a small community. We're slightly different, so it makes it hard for people to find jobs. It makes it hard for people to support their families. And when you can't find that, the anxiety and the stress from that can lead to a lot of bad things.
They don't have jobs, they don't have the ability to manage their medication. And that's a big deal for a couple of reasons. One, it's really costly for counties to restabilize somebody's health, and it's really expensive to keep somebody in jail.
Once an inmate's in jail, they have no insurance. Nothing, nada, taken away. A lot of those prisoners or inmates, they have families. And so those families are affected when they're in jail too.
You work in corrections long enough and you start to see the same people over and over again. It's getting to the point where I'm not just seeing the same people, I'm seeing the same families. I've had grandpa, I've had dad, now I'm having son. And it's a generational thing.
The family structure breaks apart, and so if there's anything that we can do to keep that together, that would be a plus.
The county foots a ton of medical bills every single year, and a majority of those come from the same people that I will see 4 or 5 times. The major factor is instability.
The accountable community of health really moves this from just a feel-good, it's the right thing to do, to a business case for why we need to make the changes we need to make, the collaboration that's going to be necessary, and the ultimate goal of improving community health. Our Accountable Community of Health regional project is the Pathways Hub model for a jail transition population.
The hub coordinator will coordinate with all the resources that they need, housing assistance, medical, mental health.
Making sure they have a primary care doctor so they can keep taking their medication or continue the treatment that they've started.
It'll save money for the county in the long run, save money for the taxpayers, and it'll benefit the whole community.
And eventually, by stabilizing them and getting them into a stronger position, then they can start take the lead on their own and get to their own appointments and get to their own things. And then they transition out and somebody else transitions in. And hopefully you do that with enough people, you make a big enough difference.
When we think about our work, it is in the broadest sense of community health and improving the systems and the processes and the services that make each of us healthy.
Maybe eventually at some point, the system works like it was supposed to be designed for. You come to jail once, you decide you don't like it, you don't come back, because you'll have that resource available to help prevent it.
It actually touches people's lives and helps improve their family life.
It's a chance to try to do something to change things for the better. And if it works, maybe that's just the first step and we can keep doing more.
Thanks very much for the video. And now we have on our panel today Allison Carlwick, who you just saw on the video, who's the director of Better Health Together, Accountable Community of Health. Allison, thank you for joining us today. What's your perspective on where you've been? You can turn it over to you now.
Certainly. Thanks so much, and it's great to be with everybody today. That video just sort of evokes all of these feelings of pride in our region as our accountable community of health has developed. In the Spokane region, we've had a long history of collaboration, both in the urban area and across our rural, both health and community systems. So when we launched our first set of community health planning, it wasn't a big leap of faith for folks to come to the table. I think what has transpired over the last 2 years is the development of a really significant amount of shared understanding about each of the sectors or segments that make you healthy. And we're starting to get some really powerful shared language that is resulting in partnerships like we are demonstrating with the Pathways Hub model and our healthcare system and our social determinative health system and our criminal justice system. So we feel incredibly excited about that. I think as we have reflected back at the sort of midpoint of our ACH development, we have really appreciated the wisdom that the Healthcare Authority had in the strategy around local involvement. In our region, I think we're so geographically removed from the I-5 corridor or Olympia that we have quite a spirit of independence and we'll figure it out on our own. And I think if you tried to do the level of health transformation that we're talking about doing, and it had come from the west side telling us how to do it, we would not be seeing as much success in that way. I would also just highlight that these first couple of years have been pretty process heavy for us, and we've really established the right set of partnerships to move the work forward. And without the demonstration dollars, I think it would have been really hard to make transformative changes, but those dollars are really going to give us the working capital that will be necessary to meet some of our really audacious goals of being the healthiest region in the state.
Okay, great. Well, Allison, I think I just want to say that Washington State is very lucky to have you as a leader, and audacious goals are what we need to have to drive this work forward. So thanks very much. going to transition. Yeah, thank you. We're going to transition now. I'd like to introduce Erin Hertel of the Center for Community Health and Evaluation. The Healthcare Authority has contracted with that center to evaluate the Accountable Community Health Initiative. CCHE is helping us to understand how ACHs are working, setting community priorities, engaging in health improvement activities, and contributing to the Healthier Washington initiative. So I'm going to turn it over to Erin.
Great, thank you, Dorothy. And I want to start out with just a very quick look at how we're doing our work here as an evaluation partner with the Healthier Washington. We have a couple key goals for the evaluation, and the first is to facilitate continuous learning, strategic learning throughout the initiative to contribute to individual ACH success and the initiative's success overall. And the second goal is to understand and measure the impact that ACHs are having, and we're doing that across the way, but we're particularly doing that at the end. We're understanding progress and development and challenges to be able to foster this strategic learning, and I'm going to share a little bit of just-in-time information with you today. One of the first things that we do as an evaluation and did in this initiative is to develop a theory of change, or sometimes it's a logic model, to be able to understand what the ACH role is and what development will look like. And this forms the basis of our evaluation, but it also allows us to describe what ACHs are doing at a 30,000-foot level across the state. We developed this theory of change collaboratively with Healthier Washington and with ACHs so that it was a shared vision. And you can see the visual here. I would describe it by saying that the foundation for this work, as Allison just mentioned, is using process and partnership to build those functioning organizations that are necessary to the basis of this health improvement work. And then move into that middle circle section that is meant to represent the expanding health improvement efforts, strengthening collaboration, and any policy practice or system change that will really get you to those healthier communities. And that means both changing the triple aim about cost, quality, and access to healthcare, but also improved health equity and those population health pieces that are so important to really moving health ahead. Wanted to share a couple different slides of just insights given where we are at the moment with ACHs. And one of the questions that we ask in our evaluation is what's contributing to effective ACH functioning? And we have a couple emerging success factors that we're seeing in successful ACHs across the state. And we are able to name these and then use them as a way to support strategic learning and best practice sharing across the state. So the first one here is bolded because, as Allison mentioned in her comments, ACHs are demonstrating a capacity to bring together multi-sector participants in a way that we just haven't seen at these tables before in the ACH regions. And that is allowing for conversations to happen, project planning, and other shared learning and understanding that really, again, forms the foundation of this health improvement work. The rest of the bullets that are on here, I won't go through them one by one, even though they're all important for the work. And this is hard work. Being able to come together as a region, create a shared vision, have adequate and dedicated leadership, staffing, and capacity, and then start to take that through a participatory decision-making process and move to action, but bring your community along with you. When this is working, these are the things that are very successful to ACHs, and they also are challenging to crack this nut. So we're providing support, and ACHs are really leaning in as partners in this work across the state. The next slide transitions slightly to things that are rising to the top as ACHs face the next phase of development. And I won't get into details about the Medicaid transformation demonstration because that's coming up in a few moments, but just to name that as with the advent of the demonstration, this is creating the ACH role to evolve, and it brings both challenges and opportunities. ACHs will be transitioning to nonprofit entities if they aren't already. And that is a significant shift in governance, in staffing, and in roles. And ACHs are leaning into how to do that work. There also just is a significant change in scope, focus, and capacity that's required under the demonstration. And I want to underline here that the vision of the demonstration and the vision of SIM are highly aligned. But the scope, given what you'll hear from Mark in a few minutes, is a bit different, and that requires different levels of operationalizing that work at a regional level. And then, as Allison also alluded to, there's a balancing act between the amount of statewide guidance that's needed and regional flexibility to make sure that there's clear expectations of ACHs, particularly as federal dollars are being spent, but also that there's enough regional flexibility so ACHs are able to bring this to life in their region and really make it their own. I'd like to end with a glimpse into some of the concrete data that came out of a survey that was done last fall of ACH members. We survey annually ACH members across the state and report back findings at a statewide level, which is what you're seeing here. It's a statewide roll-up, but also at an individual level. And we survey about ACH functioning and also the perception of members of a contribution to regional health improvement. And I know there's a lot on this slide, but the point I'm wanting to make with it is the high degree of agreement that you see represented in the blue here. So light blue is agreement, dark blue is strong agreement, with some pretty powerful statements about how ACHs are contributing to regional health improvement in their region. And those are statements that include the ACH being a worthwhile use of my organization's time and resource, that they're making a positive contribution to health improvement in the region, and that they're increasing collaboration across organizations and sectors in our region. So as the evaluation team, we search out a variety of voices and use a variety of data collection methods. And this is one that we value highly because it lifts up the ACH members' voices and their opinions of ACHs themselves. So I wanted to close my section on that note.
Great, thanks, Erin. Again, this is Chase, and I get to introduce another ACH video. We were able to see a little bit of on the ground and Better Health Together. Now we're going to take a look at the Olympic Community of Health and the work that's happening there to move that region to action. So without further ado, we're going to play the video.
We have far too many deaths from overdose each year, and then beyond that, far too many hospitalizations.
Prescribers have been trained to treat pain, and the way they treat pain is by prescribing pain medication. That is how they're trained, that is how the system works.
They first start by getting legitimate prescription for narcotic pain medication from a dentist or a doctor. After that prescription dries up, they beg or borrow it from others, and then that eventually turns into buying those pills on the street.
Because the disease drives people to crime, but it's not solved by just jailing people.
The police now become the front lines to address this problem, and that is a huge issue. It is not something the police signed up for. It's not what's right for these patients, for these individuals on the streets.
And when it's a health issue, we ought not be talking about punishment. We ought to be talking about treatment and health.
If myself or another mental health professional are not called to see somebody in the hospital or the emergency department, the cycle of use continues. They go back out, they use, and they can become ill again pretty quickly.
The ACH is the umbrella organization that's invited all of these different aspects of our community who are touched into a conversation.
We are one of 9 accountable communities of health, all committed to addressing really tough, complex health issues that no single sector or tribe can tackle alone. And when you look at what those issues are, this opioid crisis, this is a statewide issue, it's a national crisis.
And so bringing the many partners together allows the crisis to be addressed successfully, preventing future behavioral health and health issues.
We are a connected community, and in order to fix this, we need to work together.
One of the recommendations that the Olympic Community of Health makes is that more primary care providers become certified to prescribe Suboxone. That would drastically help treat the people in our community who are addicted to opioids. Doctors and dentists want to do the right thing. We're not having to twist any prescriber's arm to prescribe less narcotic pain medication.
Imagine what's possible when you support those kinds of collaborations, when you make them easy.
I've seen a heroin addict who I saw in the hospital at least 3 or 4 times who got on Suboxone, and I stopped seeing him in the hospital. But I saw him around town, and he looked good. He looked like he had a family, and then I heard he had a job. That's why I do it. That's why we do it. And that's what can be done.
Great. So it's so exciting to see an ACH in action. That was the Olympic Community of Health, and you saw Elia Moore, the director of the Olympic Community of Health. And I'm going to turn it over to Elia to tell us a little bit more about what's going on in their region and what's ahead. So Elia, I'll turn it over to you.
Hi, good afternoon, Chase. I'm going to take the baton where Allison left off and move from kind of where the ACH is now, where the Olympic Community of Health is now, and then where we're heading. And I call this from planning to action, because as Allison said, the first several years were all about process and planning. And as you saw in that video, we're now actually changing how care is delivered, and we're changing the experience of care that patients receive, particularly as it pertains to opioid use disorder in our 3-county region. So the Olympic Community of Health, Jefferson, Kitsap, and Clallam, we're moving forward with our 3-county coordinated opioid response plan. We are folding that work into the Medicaid demonstration project as that unfolds. And alongside of that activity, we're also moving forward to get our organization ready to be the single coordinating entity for the Medicaid demonstration projects in our 3-county region. That includes significant investment in organizational structure. It also includes enhanced provider engagement and enhanced tribe engagement. We are soliciting ideas from our community for optional projects under the Medicaid demonstration transformation project, and we are specifically looking for project ideas that will really be able to be scaled up and sustained across the 3-county region, that will impact a lot of people on Medicaid, that will really move the dial on some of these key metrics that that will drive us closer towards the triple aim. We're looking for projects that will address community health needs. Obviously, opioid in our region is a major community health need, but we have, through our regional health needs assessment, identified several areas of investment that we would like to see. We're looking for projects that are transformational and projects that are implementable in the time period. And then we're looking for projects which I say provide bang for the buck. So these are projects that will yield a good amount of output and deliverable for a small amount of investment. So we're looking for things that we can prop up quickly and move forward with quickly. So when looking forward over the next 5 years, I would say our short-term priority really is, as I've said, it's a demonstration project. It is a heavy lift for the ACHs. We have a lot of work to do. Our number one priority over this next year is to get ready and select the right project to achieve the right results. Moving forward over the next 4 years after that, along with continuing implementation of demonstration, we're also looking to address some serious strategic priorities. We're looking at addressing obesity. We have a major oral health access problem in our area. We, like many others across the state, have a housing stock problem. So looking at how we could work together and leverage resources to provide a higher availability of housing. And then the last thing we're focused on, and you heard in the video, is this idea of a connected community. And it's identifying where we're interdependent across sectors, across organizations, and also with our tribal partners. Identifying where we're connected and finding ways to build bridges across those different areas. Moving forward, you know, I say the Medicaid demonstration project, it is a demonstration. It is a big experiment. For us to be successful, we have to be thinking about converting the demonstration into what I call the new normal. So whatever we put in place now, whatever we're piloting and testing, we should be looking for things that we want to become permanent institutions for our health care and health and wellness delivery system. So that's where we're headed, and you can find out more about the Olympic Community of Health at www.olympicch.org.
Great, thanks, Elia, and thanks so much for your leadership in the Olympic Community of Health. And for the web links, just so you know, we will highlight those in a few slides after we hear from Mark Province regarding the ACH role in the Medicaid demonstration. And I just want to first mention, Elia mentioned the Regional Health Needs Assessment and that they're ACH selected community priorities. And I just wanted to note that that's a process all ACHs went through. And there were themes that came out of that regarding care coordination, access to care, full person care, linkages to community supports and resources. So know that ACHs have had the discussion around what their priorities are. You heard two examples here today, and we want to connect you to other ACHs and their work. And one of the opportunities we hope to support those priorities and also to move the state forward is the Medicaid demonstration. And so with that, I'm going to hand it over to Mark Province, the Director of the Office of Medicaid Transformation, to talk a little bit more about the demonstration and where the ACHs fit in.
Great, thanks, Chase. So just to frame the remaining few slides, I'd like to recall, going back to Dorothy's remarks, that the demonstration, as significant as it is really one component of Healthier Washington. It's just as the SIM grant, it's in service to the three goals that Dorothy described. Also going back to something that Aaron said, the demonstration does give a boost to the activities that we've launched with SIM. It adds some fuel, and some would say it adds rocket fuel to the goals that we're pursuing. And I think both Elia and Allison did a great job illustrating the ways in which the ACHs really are grabbing this challenge and running with it. But first I want to remind us who we're serving in doing all of this, because it's the Medicaid population in our state. Many of you may know, and some of you may not, that Apple Health, our Medicaid program, covers nearly 2 million people in our state. And with the Medicaid expansion, a number of these folks are newly eligible adults. A lot of us who are used to the Medicaid program may think of it as serving primarily children, pregnant women, but with the Medicaid expansion, we really shifted a lot of focus, and we've seen this region by region, to an adult population. That brings new challenges and new opportunities to us. I'd like to talk a little bit about the Medicaid transformation goals. I won't go through all of these individually, but what I'd like you to note from this slide is, again, how each of these goals really aligns with those three circles to the left of the diagram. We do want to integrate physical and behavioral health services. That's a very significant goal in both the SIM grant and in the demonstration. It's a significant goal of our governor and our legislature, and we are investing a lot of our attention and resources into moving the state forward in that regard. We're also paying attention to value by wanting to move the way in which we reimburse for services, the way in which we purchase services, the way in which we provide incentives to providers away from fee-for-service, away from rewarding volume and really more toward rewarding value, which carries its own challenges, some of which have to do with making sure that we can measure the outcomes that we're pursuing. We also want to support provider capacity to engage with us, with our ACHs as very significant partners with the ACHs in making those transitions. And also address not just the typical clinical care services, but also social determinants of health. And I think you got some good examples of ways in which we're pursuing that in the videos that you saw. ACHs do play a very critical role in the Medicaid transformation demonstration. And significant components of that role are illustrated here. ACHs coordinate and oversee regional projects. And again, you saw good examples of the types of projects that are possible in both the videos and also heard about them in the remarks from Elia and Allison. The ACHs will be applying for transformation projects, and I'll describe the framework for that on the next slide. But before I get there, ACHs will also be soliciting community feedback, and actually have already started soliciting community feedback in how they will construct essentially their project portfolio that they will bring forward under the demonstration. And then finally, deciding on distribution of incentive funds to providers. It's important as a reminder that the Medicaid transformation demonstration isn't a grant. It's really an incentive-based program. What the federal government has done is given the state the opportunity to earn incentive payments by demonstrating what we can accomplish when we all put our hearts and minds and resources together. And so as milestones are accomplished over the course of the demonstration, incentive funds are released and then made available so that they can be allocated with the cooperation of the ACHs to really reinforce the kinds of transformational projects that they're engaging in. So I mentioned the project framework of what we call our project toolkit. Many of you may have seen this. If you haven't, and if you're not familiar with the project toolkit, I encourage you to go to our website and you'll get a lot more detail than what I'll be able to present right now. But this gives you an illustration of what we include in our project framework. And if you think of it kind of from the bottom up, the first level, what we call domain 1, really has to do with the kinds of capacity building necessary to achieve the projects in the upper 2 stories of this house, if you will. And those involve creating financial sustainability opportunities. It involves making sure that the workforce that we're bringing to these projects is the right combination, adequately trained and ready to go. And also that we're investing in systems for population health management. And this becomes very important, again, in measuring over the course of the demonstration how effective we're being in achieving the goals that we've set. The next level up has to do with care delivery redesign, and you'll see 4 project areas illustrated here. Bidirectional integration of care, and I should note that in our project toolkit, this is a project that is required of every ACH. ACHs can then choose from among the other 3 projects in that care delivery redesign layer. Community-based care coordination, an example of which I think was illustrated well by the video that you saw from Better Health Together. There's also transitional care, paying attention to people either at risk of entering into institutional care or coming out of institutional care. Really, again, with an emphasis on making sure that we've got people attached to the right type of care and we're expending our resources wisely. And then finally, diversion interventions, which has a lot to do with making sure that we're not using the emergency department, for example, when we could be using primary care settings to deliver the appropriate level of care when it's needed. And finally, the prevention and the health promotion layer, which includes, again, 4 projects here. The first of which, addressing the opioid use crisis, is a required project of all ACHs. And again, I think it's a very good illustration of ways in which that crisis can be approached in the example that you saw from Olympics. Also included in this domain are projects related to improving maternal and child health, addressing the need for oral health services, which again is very important, especially as we shift services to adult populations, some of whom are in great need of oral health services. And then chronic disease prevention. So those are all, if you will, population health oriented and health promotion oriented projects. So together these represent essentially the potential ingredients for a project portfolio that each ACH will be bringing forward. And as Allison and Elia are all too painfully aware, the ACHs are about to engage in a very concerted effort over the course of this year to bring those project portfolios forward. So with that, I will hand it back to Chase.
Great, thanks, Mark. So you've heard some of the regional priorities and seen a couple of examples from BHT and the Olympics Community of Health. Unfortunately, we have limited time today. We weren't able to feature all 9 ACHs and the important work that's moving forward there. So we do want to point you in the right direction for next steps. And you can see here a list of each of the 9 ACHs. You can see their director, point of contact, and then the website where you can access more information, find out about meetings, find out about some of the projects that are underway. So check those out. And we also have more information on our Healthier Washington site. So you can see the link here. You can find out more about the Accountable Communities of Health. You can find out more about the Medicaid demonstration. and other important initiatives within Healthier Washington. So check that out, navigate, ask questions. And to that point, today we do have some time to dive into some questions and discussion. And I'm going to check with Laura Zeichkin, the Deputy Chief Policy Officer here at the Healthcare Authority, to see if we have any questions that came in, and you can help facilitate some discussion.
Sure. So just as a reminder, now is the time to type your questions into the chat box, the questions box. But we have been receiving several questions throughout the webinar. Dorothy, I'm going to start with you. We received a couple questions about how we define population health. We talk a lot in Healthier Washington about improving the health of populations. Maybe you can speak to that a little bit more and what we mean when we talk.
So thanks, Laura. And this is a question that I think is at almost the very top of my list of frequently asked questions as we've been moving forward with Healthier Washington. And actually, to me, it's an example of how when you come together with different sectors, you find that there are terms that everybody uses, but they have a little different meaning depending on who you are and where you sit. So I think one way to look at this is when we're thinking, for example, about the Medicaid population. That's a group of 1.9 million people, and we're trying to engage on both improving the services that they receive, but also improving the health of that population through various health improvement activities. Another way to look at it is the whole population of the state of Washington. And in that case, you're focusing, I think, more on the health things like the risk factors, the environmental health issues, the more public health kind of focus that you can get into when you're really trying to focus on the overall population of the state of Washington. The difference between those two is that your levers may be a little bit different. In the case of our Medicaid population, imagine that you're trying to say, for example, improve the blood pressure readings from the people in that population. I'm just making this up on the fly. Well, at the end of the day, when you do that for a large population, when you step back and look at from a public health perspective on improving the the health status of that population, the work that you can do just focusing on a particular area is going to both improve the health of the focused population, but at the end of the day, roll up into a population health measure as well. So the fundamental difference, I think, between when you're in a health care delivery system talking about health improvement, you're really almost talking about each individual person that you see. The change in the healthcare delivery system now and the way we're changing the way we pay is to really focus on a total cost of care for our population. Therefore, you're still focusing on the individual, but you can also then change the population that's being served there. From a population health perspective, then from a public health perspective, they're looking at not only the individuals and how they make up subpopulations, but the overall picture. At the end of the day, it's the denominator that matters. And if we can't, and no matter what area you're in, if you're in a clinic or you're in a region or in a county, if you start with the denominator, which is the population you're trying to impact, then you're, at the end of the day, impacting the health of that population. I think this would be a fantastic webinar in and of itself to really go into the different terms and how people use them. But I think the fundamental kind of thing to keep in your minds is that there's a denominator to everything we're doing, whether it's a county, a region, a population of diabetic patients, whatever it is. The denominator is what matters, because that's when you can start to measure, literally measure improvement over time. That's a very long-winded and off the top of my head response to an extremely complicated topic. Well, thanks for giving that one to me.
Of course. Thanks, Dorothy. So Allison, I'm going to direct this question toward you, and I'd be interested, Elia, in your additional thoughts. So Aaron spoke to a shift in scope and focus with the introduction of the demonstration. Elia, you spoke to moving from planning to action and being in this phase that's really focused on the demonstration. Allison, can you first speak to how the accountable community of health is evolving while also considering maybe the original vision of the accountable community of health, and how you continue to be responsive to community priorities, whether they're in direct alignment with the demonstration or not?
Well, I'm super lucky in our region because the demonstration aligns perfectly with our priority areas. I think our biggest challenge is in a region without a large number of providers, how to move forward on all of these priority areas and demonstration efforts at the same time. We've been really lucky that the folks that we have assembled, probably heavily influenced by our rural partners, where the makeup of the population has a large percentage of both Medicaid and Medicare folks. So they've been thinking in this value-based payment, value-based environment for some time. That we haven't seen any resistance or lack of focus happening as we move through the process. I think there's just great alignment to try and take advantage of what we would deem sort of a once-in-a-generation opportunity, following on the once-in-a-generation opportunity the Affordable Care Act provided for our region. So there's just great momentum and very little concern in our region that the waiver or the demonstration efforts are going to detract from our broader community goals. I think we see this as an opportunity to really accelerate that broader system change using this as that mechanism.
This is Elia. Allison and I happen to be in the same room. You know, the Medicaid demonstration project is the result of a lot of hard work for a lot of very smart people. And I think the end result of it is going to be better care for the 600,000 plus people in our state on Medicaid. No doubt about that. I'm very excited about it. It is a once-in-a-generation opportunity to help leverage and bring that to its full possible potential. I think the question around distraction is a very realistic one. As you saw in our 5-year strategic planning, we've dedicated the first year to making sure that we could implement the Medicaid demonstration project and whatever sub-projects fall under that. But to be completely clear, the way that we're approaching this is we're starting with what it is, where's the need? What is it that we need to transform within our delivery system, within our community clinical wellness system? Where is the opportunity for transformation? And then we take that, that's the regional health needs assessment that Chase was talking about. We take that and then we overlay the opportunities brought to bear by the Medicaid demonstration project. And where there is overlap, that's what we go after with the Medicaid demonstration project. Anything that is not in that bucket, and there are some things that we would like to do that are not necessarily in that bucket, that is still the ongoing work of the Olympic Community of Health. And I do want to point out that the Medicaid demonstration project is a Medicaid-focused effort, and I can at least speak for our region, which holds the oldest county, oldest and wisest county in the state, Jefferson County, average age of 55, where the majority of residents there are Medicare. So we need to be looking at issues that pertain to the aging population as well if we're going to take a holistic approach to health transformation.
Thanks so much. So we have a lot of questions about the demonstration and just kind of more operational things around dates and milestones. So Mark, I'm wondering specifically if you can speak to some of the milestones that ACHs and the state will be looking at for the next year, and when those might occur.
Great, thanks, Laura. So there are some significant events happening over the course of this next year. First, I'll mention that the demonstration is a 5-year demonstration, and it began January 9th of this year, so we're already 1 quarter into our demonstration activities. But for the remainder of 2017, there are a few things that I'll highlight. ACHs will be completing a 2-phase certification process. That's not to say that ACHs aren't already very well established, but there are some specific requirements, some specific questions that we're asking the ACHs to respond to, which really are just intended to help the ACHs and to help us assure that they will in fact be successful in bringing forward the project portfolios that I mentioned earlier. Speaking of the projects, the bulk of the focus of this year really is on the development of those project portfolios. So if you'll recall that diagram that looks like a house, there are 2 required projects of each ACH, and then in addition, 2 optional projects, one from each of the upper 2 domains, that at minimum the ACH will be bringing forward essentially as a project plan to us. So that project plan will be developed over the next months with the goal of having the project plans completed by the end of fall, which will give us, the Healthcare Authority, and also a contractor, which we are calling an independent assessor, the opportunity to evaluate those project plans, make sure that all the right ingredients are there, and that they have the maximum potential for success. With that, the intent is to be in a position to launch those projects in early 2018. I should also mention that over the course of the remaining then 4 years of the demonstration, there will be some initial activities that are probably a little bit more process-oriented, having to do with making sure that all the right ingredients are in place for the projects, that they're well established, and that really some of those foundational building blocks are in place. We will then move over the course of the demonstration, the remaining years, from process-oriented milestones to outcome-oriented milestones. And that's extremely important because by the end of the demonstration, we must demonstrate to the federal government and to ourselves that these innovations, these projects are actually sustainable beyond the course of the 5 years. So even though we keep talking about this as a 5-year demonstration, and I think it goes back to some of the things that both Ellie and Allison mentioned, we need to make sure that these are sustainable, that these are interventions that will last beyond the lifetime of the demonstration. So those are some of the most immediate areas of focus for us, and we're already underway pursuing those.
Great. I'm going to give the last word to Allison and Elia here. That's a lot of work that Mark just outlined. And we received a lot of questions about how you're engaging folks from across sectors, for example, counties, social health sectors like housing and transportation. How can people get involved, or how are you engaging folks in your specific accountable community of health, and how can people get involved if they're not already? And Elia, let's start with you.
Oh, okay. Hi, this is Elia. No doubt, this is a heavy lift, and it's gonna take an all hands on deck approach, and that's the approach we're taking at the Olympic Community of Health. We are calling for letters of intent right now for optional projects under the Medicaid demonstration. We want people to submit their ideas to the OCH. We have a community committee that is prepped and ready to review those ideas and move forward with the request for application process. All of our materials are online and all of our meetings are open to the public. We have a newsletter system so you can receive information as it becomes available, and this is a very fast clip. Mark is right. We're already 3 months in to a 5-year demonstration, and we are full steam ahead. So I really encourage people to go to the website of your ACH, and most of us have newsletters, and it's not all of us, and sign up to receive that information. We hold at the Olympic Community of Health partner meetings quarterly or at least every 6 months. and are always looking for opportunities to speak and talk to your boards and your constituents about what we're doing. The only way that this is going to work is if everybody is in it together, and so the outreach and engagement piece is instrumental.
I think that's great, great advice. I think every ACH around the state sort of just stands open to further engagement. At Better Health Together, we have, over the last 6 or 8 months, been hosting community strategy meetings as part of both our social determinant of health strategy mapping and our population health, with a really sincere effort to not have people come to us, but rather to have our team go out. So our reach has been broader with folks who are connected to health, but not integrated into the community health system. So I think that's felt really encouraging to start building the local movement that will be necessary to achieve these big goals.
Great. Thanks so much to our panel today. Much appreciated. I do want to point at the Healthier Washington website, where you can find the videos that were shown today, as well as more stories around Healthier Washington. Also, the Healthier Washington website is listed here, where you can find more specific information about the demonstration, about accountable communities of health, and about Healthier Washington. We'll also be posting the webinar slides and recording there in the next few days. Thanks everybody for coming today, and we look forward to our next quarterly webinar.